people.
We timed the previous one. And we did a really good job. Okay, ready.
Ready, go. Okay, we are the Great Plains Rural Policy Network. We currently have 3 organizational network members: Avera Health, a health system in 5 states: South Dakota, Minnesota, Iowa, Nebraska, and the Nebraska Housing Developers, and the Neighbor Works Northeast Nebraska. Do you want to say something? Oh. Can. And I am Fischer-Clemens, and this is Danielle.
I am Danielle Hill. Don't know where they got that picture.
So, when we formed the Great Plains Rural Policy Network, we actually had 14 members from 6 different states, very rural states: Idaho, North Dakota, South Dakota, Nebraska,
Montana, and Minnesota.
And that in itself presented us with some very interesting dilemmas as we met together to discuss what our issues might be in that huge span of space. This picture of our network represents the 14 members when we were, which was at a point in time where we had our largest contingent of membership. We were in Memphis at this point in time, and we really were at this point trying to figure out how that diverse population state could actually work together to accomplish a goal. And you can see the list. We had folks from community economics, we had community action network, a development network. Creighton had a law office involved, housing developers, and it was huge challenges.
To bring all those people together with all those different missions and passions. Our biggest challenges beginning as a network were the diversity of interests, obviously, and how those all intersected. How do we connect? We do this every day. I don't know anything about healthcare. So those were our 2 biggest challenges, is bringing those things together and getting on the same page to work together.
We had, again, our 3, and so in our early policy activities of the network, we focused on health reform and on the Affordable Care Act. And then in 2008, the network actually continued to work on health reform and affordable housing and immigration. They became the focus of those 3 entities became our focus. So, and then it was in 2010, as we worked on these 3 issues, we decided that the one thing we could do as these states was to develop a way to meet with the congressional delegations to talk about the issues and concerns that we had within all of those states. And so it was then in 2010 that the network headed off to Washington, D.C. to do a meeting that included Hill visits with the congressional delegations of, at this point in time, we did all of South Dakota, Montana, and Nebraska, talking about these 3 specific issues.
So in 2012, we were successfully funded with a policy project grant. And as far as the immigration policy work, we really were focusing on the DREAM Act. And we also lost one of our partners, which was Appleseed Law, Center of Law in the Public Interest, a social justice group. So we kind of had to drop that because the expertise wasn't there anymore within our network. But we were able to develop some information on housing policy work, and part of that included trying to promote the National Housing Trust Fund and many rural communities throughout the nation not losing access to USDA's mortgage loan programs.
So as we talked about healthcare reform, one of the things that we at Avera were working on was telemedicine. And we felt that as you looked at delivery system reforms, which is the one area that you don't hear a lot of talk about, but it's a huge piece of the Affordable Care Act, is how do you deliver care differently? We felt that we were the perfect example in rural and how to deliver care differently, and that we needed to look at it in that way. And one of the things that we identified very early on as a health system and worked with educating our group about was that there are many restrictions that are placed on by laws in states and federally on how you actually can do telemedicine and how you can provide the access and do the work that relate to that. One of the other issues is certainly the reimbursement. It's interesting that there's a policy out there that says that we should be reimbursed less in rural to provide access to our rural consumers through a telemedicine way. One of the other issues that we identified very quickly in these restrictions was that physicians, if you were going to provide telemedicine across state lines, the states had policies that didn't necessarily allow that, and to this day still do not. But we are still moving forward, working to identify ways that we can figure out how to create a compact that allows that a physician in South Dakota can, because they're licensed, could be credentialed in another state, but they didn't have to transfer their license in order to see a patient through a telemedicine network in another state. A way that we can actually move that forward. One of our other areas was federal law, which is called EMTALA, which is the Emergency Medical Treatment and Active Labor Act. And it defines very clearly how you can treat and manage emergency room patients. And what we learned very quickly is, again, there's some rules that say you have to be seen, and that may be interpreted by some to mean that you have to be physically seen. And we've interpreted that that's not necessarily the case. We've been meeting with the delegations to say that there are other ways to do this and working towards that. So as we continue to look at how do we provide access through telemedicine to rural folks in a network like this, we are constantly dealing with the policies of states as well as the federal government, and we continue to work on that.